good afternoon, everyone, and thank you for joining us today. For this session on best practices in falls risk management, the continence assessment. And Happy New Year to everyone. I guess this is the first time we're getting together in the new year to continue with our community of practice. So my name is Frida Poirier, and I'm going to be the facilitator for today. I'm the long-term care best practice coordinator covering the Northeast Lynn. So in partnership with Ebo McDonald, Amy of the Champlain Lynn, Amy Reed, Simcoe Muskoka Lynn, and Barbara Anderson from West Park, we have developed today's presentation to support our falls prevention and management community of practice. So today we're using WebEx for our presentation. As you can see on the screen here, if you need to get the event number for technical support, you can click on the event info tab on the top corner. To go to full screen, you can click on the view and then full screen at the top right corner, which is shown on the screen here. As well, there's a question and answer panel where you can type in your questions during the presentation, and we will do our very best to address them throughout the presentation or at the end of the session or through email. So the objectives of today are to present you with an overview of incontinence and help you become more familiar with the elements of a good continence assessment. So as you see here, this is the newly admitted residents algorithm we've been looking at and where we started. At the beginning, we started with the falls risk screening conversation, and then we're focusing more into step 2, which is the assessment. So it speaks to completing a multifactorial fall risk assessment. And our presentation prior to this, we did have Eric present on functional mobility and assessment. So we're moving into the next part of this, which is the other fall risk factors and their assessments to look at. So as part of that, there's a number of them here, and today we're going to be speaking to continence. And we have a continence advisor that's going to present for us. So just a couple of notes. Bowel and bladder risk factors for falling. Incontinence and urgency can lead to residents rushing to the bathroom, as well as more frequent trips to the bathroom. This can also lead to urine getting on the floor and therefore presenting a slip hazard. Dehydration and infections can lead to a weakened condition for the resident, which can also contribute to poor balance and impaired decision making. So here you'll see some of the factors for bowel and bladder risk. On this slide, you see the consequences of urinary incontinence. So there's decreased quality of life, social isolation, urinary tract infections, skin impairment, and falls and fractures. For the sake of time, our focus today will be on urinary incontinence. So here's just a little cartoon that speaks to Hello Incontinence Helpline, can you hold? So moving forward with that, we called the helpline, and Barbara has offered and so kindly joined us and helped us create this presentation today. So at this time, I'd like to introduce Barbara Anderson. Barbara is a clinical nurse specialist at West Park Healthcare Center, Toronto. Barbara holds a clinical professor appointment in the School of Nursing, Faculty of Health Sciences at McMaster University, As well, Barbara tutors the McMaster University Nurse Continence Advisor Program. Barbara is also the author of a continence book that we are going to share with you later. So at this time, Barbara, I guess you can take over.
Hello, everybody. So it's my pleasure to provide this presentation today. And I'd like to start first with this depiction of a clinical model for improving continence care. Because as we go through the presentation and we think about the components of an in-depth assessment for urinary incontinence, what I want you to think about is what is ideal clinical care for urinary incontinence. And then in the go forward, to do a self-assessment in your own facility about what components of ideal continence care do you currently have in place and where are the gaps, and then making a plan in terms of how you're going to bridge the gaps in making improvements to your urinary incontinence assessment processes. So this is a depiction of elements of optimal continence care, and today we're focusing on how to conduct an initial assessment. This can be done in your facilities by an RN or an RPN. It's a second level in-depth assessment of urinary incontinence, and the detailed assessment will lead you to identifying a number of contributing factors. It will also lead you to identify the type of urinary incontinence, and then to look at the contributing factors that are modifiable in terms of then a plan of care for conservative behavioral interventions that can significantly improve the patient's continence status. I also would like to make you aware of specialists that can provide additional assessments. So in Canada, we have a nurse continence advisor role, and there are a number of nurse continence advisors. Urologists, gynecologists, urogynecologists, and geriatricians all often have a specialty interest in urinary incontinence. For those patients who have intractable incontinence where you cannot make improvements to their continence status, then we want to look at the best possible management in the best possible product that you're able to secure for your facility in terms of managing containment and comfort and quality of life with the products that you have. So what is incontinence? We have an International Continence Society, been a member for a decade now. Physicians, all those specialists that I named, physiotherapists and nurses across the world belong to this organization. And the International Continence Society, you can Google online a lot of resources that have open access for you. And the ICS has defined urinary incontinence as the complaint of any involuntary loss of urine. And this definition was updated in 2003. Just some stats in terms of who is affected with urinary incontinence. And so the prevalence in Canada is 1.5 million Canadians. 5 to 10% of those of us that live in the community suffer from this problem. In the acute care sector, 10 to 20%. I work in a rehab and complex continuing care facility, and in our facility, 50 to 70%. And for your long-term care sector, 40 to 70%. So it's a significant problem. In terms of gender differences, urinary incontinence affects 1 in 4 women sometime in their life. It's also a problem for men and affects 1 in 10 men. So what are the requirements of continence to have bladder control? Well, there's 4 things that all of us need. The first is awareness of the urge to void. So in the assessment, you will see questions that we ask about sensation. So do you have the normal sensation of the urge to void? Are you aware of passing urine? Are you aware of being wet? So we ask those sensation questions. The second requirement is being able to get to the bathroom. So I hear you had a presentation previously on functional components and mobility. So can the person ambulate, transfer, and their mobility for getting to the bathroom? And then their ability to postpone. So are they able to suppress the urge until you reach the bathroom? So we ask questions about how long can you wait. So if you were to be out in the car and you needed to go, would you be able to wait more than 15 minutes? If you're ringing a call bell, can you postpone more than 5 minutes? So getting at urge suppression and being able to hold. And then the fourth is getting at emptying problems. So when you get into the bathroom, can you initiate a void? So we ask questions about hesitancy. Do you have to wait for your stream to start? Is it a slow stream? Do you have to strain? Do you feel like your bladder has emptied completely or not? Do you need to void a second time? So those kinds of questions getting at emptying difficulties. So this is a depiction of the normal voiding cycle, and I really like this because the whole education piece can be captured in this diagram. So our bladders are a muscle, and there's essentially 2 phases to maturation: the storage phase, which is the longer phase, and an emptying phase. And during bladder filling, your bladder muscles should be relaxed. If your bladder muscles contracting during filling, then you're going to experience I gotta go urge symptoms and not being able to hold on. So the muscle's supposed to be relaxed during filling. Your urethral sphincter, which is your closure mechanism, should have a tone at this point, and your pelvic floor tone. With the first sensation to void, your bladder muscle should still be relaxed. Your urethral sphincter contracts and your pelvic floor contracts. So this is a little bit more of an active holding on and postponing. With the normal desire to void, your bladder muscle has to contract. So if a person's experiencing emptying difficulties, it may be because the bladder muscle is relaxed at the voiding, at the emptying phase, and in order to effectively empty, your bladder needs to contract. And your urethral sphincter needs to relax, and this is under voluntary control. And your pelvic floor relaxes, and you're able to pass your urine. Part of what helps with the sphincter relaxation and the pelvic floor relaxation is sitting in a squat position. So on a bedpan, you wouldn't get a good squat position, so this is why it's so important for people to be able to sit on a toilet because you need the squat position to facilitate that relaxation of your pelvic floor. And then you cycle back to bladder filling, the muscles relax, you have your sphincter tone and your pelvic floor tone. So patients with urinary incontinence either have a problem with the storage phase, or they have a problem with the emptying phase, or it could be mixed, both storage phase problems and emptying phase problems. So this is a good diagram to keep revisiting as you think through how the bladder works. So there's actually 4 types of urinary incontinence: stress, urge, functional, and overflow. And it can be more than one type. So it can be mixed, and this is what you're going to tease out with your assessment. So I'm going to go through each one. So with stress urinary incontinence, this is related to weak pelvic floor and anything that increases abdominal pressure. So laughing, coughing, sneezing, exercising, standing during sexual intercourse, anything that's going to increase the intra-abdominal pressure on a weak pelvic floor. And this results in a small amount of urine loss, and it's most common in women, but it sometimes occurs in men following prostate surgery. What happens with men is they have two sphincter mechanisms, and sometimes with radical prostatectomy, the internal sphincter is damaged. The external sphincter is weakened because the men are managed with an indwelling catheter for a period of time, and they will experience stress urinary incontinence. In some of our continence clinics, sorry, that's my pager going off. In some of our continence clinics, we're getting referrals in advance of the surgery to teach men pelvic floor muscle exercises. The next type of incontinence is urge incontinence. You'll hear this being described as an overactive bladder. This is your bladder that's contracting during filling that should be relaxed. So it's loss of urine with a strong, unstoppable urge to urinate. It's associated with frequent urination both during the day and during the night. So what you want to tease out is there are things that can cause urgency, and you want to differentiate urgency from urge. If it's urge, it's a problem, it's a pattern, both day and night. And so in the assessment, we look at daytime and nighttime patterns, and it's common in women and men, and it's the most devastating incontinence problem because when these patients or individuals don't make it to the bathroom on time, they lose the entire contents of the bladder. So it's a big urine loss, running down legs, pooling on floor, very embarrassing. If it happens to an individual, then this causes a social isolation because they're not going to want to go out and risk this very embarrassing loss of urine happening. And these are individuals that they have to know where the bathroom is, and they have to be able to get to a bathroom quite quickly. Overflow incontinence is serious because this can cause damage to the kidney, with a backup of urine up the ureters and high pressures on the upper tract. And this can be insidious, and so you need to really have your high suspicion and radar for overflow, and that you just don't assume the patient's incontinent, because with men, especially with obstruction from the prostate, this is insidious and gradual over time, and they lose the sensation of, if our bladder was full with a liter, we would be hugely uncomfortable. But with the loss and less awareness of sensation, patients can have a huge amount of urine in their bladder and not even be aware. And so you want to ask all the questions about hesitancy, straining, slow stream, difficulty initiating a void. And this is more common in men, but it can happen with women too, with a very weak pelvic floor. Their urethra can get kinked, and it can obstruct their ability to empty their bladder. So overflow incontinence is the type of incontinence that you want to make sure you don't miss picking up on. And if you have a bladder scanner in your facility, that can help, because you can do your bladder scan screens to see how much urine is in the bladder. Functional is either decreased mental ability, and I have some additional slides coming up in regards to that, or decreased physical ability, and the patient's unable to physically get to the bathroom. You want to make an assessment whether or not this is recent onset symptoms. And if it's recent onset symptoms, you want to think about transient causes of urinary incontinence. We used to have an acronym that was DIAPER, and our colleague Sandra Wyckoff in an earlier version of our handbook coined a disappear, make this problem disappear. So all of the transient causes of urinary incontinence, if it's recent onset, think about delirium, the intake of fluid, the type and amount, unhealthy, healthy fluid, constipation, atrophic changes, depression, pharmaceuticals. I'm going to talk later about medications that can affect the bladder. Lab values, is there a UTI, restricted mobility. So if it's recent onset, it's probably something that you can address and you can reverse. There are age-related factors. The bladder muscle itself tends to contract more, the overactivity. There's nighttime production of urine, the benign prostatic hypertrophy in men. The post-void residual tends to be higher than in younger adults, and asymptomatic bacteria in 20%. On the flip side, there's a decrease in the effectiveness of the contraction of the bladder for emptying, a decrease in bladder sensation, sphincter strength in women, bladder capacity, how much the bladder can hold, and bladder compliance is unchanged. So with functional, there can be a cognitive component, and so there's 4 abilities to consider: the ability to follow and understand prompts or cues, the ability to interact with others, the ability to complete self-care tasks, and social awareness. Interpretation is recognition and recall, and this can impact continence in terms of the person's ability to identify the urge to void, in terms of their ability to remember how to respond, and locating the toilet. So remembering what the toilet is for, where to find the toilet. This may be like your man that voids in a bucket in a garbage can because of the loss of being able to recall the use of the toilet. Interaction, comprehension, and expression. So this is the ability to understand reminders and being able to ask for assistance. And self-care. This is a couple of things: voluntary and purposeful movement, so being able to remove clothing, and spatial orientation. So this is their ability to sit and their balance on a toilet or a commode. Social is attention deficits and conversation. So again, remembering how to respond and their motivation to be continent. So a structured assessment includes detailed incontinence history. Sorry, I'm going to get rid of my pager. I stuck it outside my door. Sorry about that. Fluid intake, a detailed bowel elimination history, a medical history, medications, and functional ability, and I'm going to give more details for all of this. I'm watching my time here. It's ticking away quicker than I thought. So it's important to think about onset and duration, the daytime and nighttime patterns, the pattern of urine loss, the wet episodes, how much is lost, questions about stress loss with physical activity, urge loss, and awareness of loss. So I mentioned that earlier, the awareness of the urge to void, of passing urine, and of being wet. So it's really important to tease out a recent change and look at your transient factors, and look at ways that you can better manage chronic intractable incontinence in terms of addressing cognitive or physical deficits. We're going to talk a little bit about prompted voiding in a bit in terms of strategies that are effective with patients that have cognitive impairment. So there's a history piece in terms of the questions that you ask and the detail that you get from the patient, and then there's a physical assessment piece. And so one of the important pieces is a post-void residual. And this depends on the amount of the pre-void. So you want to use a urine hat and get a measured pre-void, and then you get a post-void residual, optimally if you have a bladder scanner or by an in-and-out catheterization. The person has to need to void, so you don't want to have a forced void because you're not going to get an accurate assessment. And you may need to trend a few post-void residuals, and just keep in mind that older adults have a higher normal post-void residual. And then there's a physical examination, so for an RN or RPN, just to simply look at, for women, to look for atrophic changes. So with the aging process and the loss of estrogen, our tissues become thinner, more friable. The inner lips can sometimes completely disappear. It's very dry tissue, and so you want to look for atrophic changes in an obvious prolapse. A prolapse of the bladder that's obvious looks like a protruding egg. A prolapse of the uterus looks more like a sac, but the bladder will look like a protruding egg. And then I'm not going to give a lot of detail about when to do a urine culture, but there is a whole chapter on this in our handbook, and it's a decision to do a urine culture is based on a decision algorithm. It's very important to assess fluid intake, to look at the type, amount, and timing of fluid, to ask about how much water, milk, juice, and then to pay attention to how much they're drinking that's caffeinated beverages. Caffeine has a huge impact on bladder. It can cause the urgency and frequency, and it's important to be aware of how much caffeine. We also take a detailed bowel elimination history. There's a second level bowel assessment as well in our handbook with detail, but for our continence, urinary incontinence, we do look at some bowel elimination information, their normal pattern, their stool consistency, are they straining, do they have palate-like stools, they have a problem with hemorrhoids, are they able to differentiate between gas and stool, are they able to postpone having a bowel movement till they get to the toilet, is there any pain or blood, is there a history of constipation or chronic laxative use. And then the brain is the boss of the bladder, and so there's often a neurological component. And this is the complexity in terms of learning about urinary incontinence assessment is neurogenic bladder issues that affect whether your bladder is contracting or relaxing during your filling and your emptying phase. So neurological conditions that can impact, and I've listed them here, as well as other medical conditions that impact recurrent urinary tract infections and dementia. And then a drill down in terms of looking at medications impacting the bladder. So diuretics, the timing of diuretics, anticholinergics that relax the bladder, estrogen, sedatives, hypnotics at night might be impacting on the awareness of the need to void at night, awareness of passing urine. Antidepressants can impact if a person's not emptying and are having emptying problems, because sometimes antidepressants are clinically used to treat stress incontinence, because it can tighten the bladder neck. And antipsychotic and antispasmodic. So we do look at the medications that may be impacting and contributing to urinary incontinence. And then all the aspects of functional ability, access to the bathroom, ambulation, do they need assistance, and the use of walkers and wheelchairs, just thinking about the ability to get to the bathroom. So an incontinence assessment requires detailed assessments, history taking, and a physical assessment. Sometimes you might have a resident who cannot respond to questions, and then it's important to use a voiding diary to assist you in gathering information about their voiding patterns, when it is that they're tending to pass urine, when they're having wet episodes, how much they're voiding each time, type amount, and timing of fluid intake. You can get that information with a voiding diary. And so that can complement, you know, if you're unable to get a clear history and asking questions. So at this point, I think we're going to have everyone unmuted and open up to any questions that you might have. I haven't gotten into treatments at this point, but just what elements are required for an in-depth assessment and all the things that you should think about for an assessment.
The conference has been unmuted.
Yeah, it might be the, and I mean, she is.
So it's Frida. Does anyone have any questions at this time?
Lynn is no. Oh, it was Lynn. I'm sorry. Lynn is no. No, Lynn's no.
Oh, Frida, I think because of the background noise, maybe we should
Lynn's are. Yeah,
to type in the question.
The conference has been muted.
Sorry, Evo, I didn't mean to. I've muted the conference again. So if anyone has any questions at this time, maybe just you could hit *7 and that will unmute you individually, or you could type it into the question box. Barbara, it's Frida. I do want to say thank you. I know there's an enormous amount of information and it's hard for you to kind of compress it down into such a short period of time. I wouldn't mind if you could just explain one more time for myself the difference between a bladder and uterus prolapse. That was new information for me. Any questions, anyone?
Just a reminder, if anybody needs to talk on the phone, they have to press *7. So, Barbara, that means you too, because we were remuted.
Yes, sorry about that. Barbara, I'm just, it's Frida. I'm wondering if you could just go back to the prolapse that you talked about, and could you just explain the difference between the bladder and the uterus prolapse one more time?
Oh, you know what? I was muted again. No. I'm so sorry. I'm talking away, and no one's hearing me.
Sorry, Barbara. That was the...
Sorry. So a bladder prolapse is called a cystocele. And nurse continence advisor is trained to do a vaginal exam to grade a cystocele. And most women have a small or moderate cystocele that you will not see with just a visual examination, but a trained care provider can feel that. It feels like a large ball on the surface of your index finger when your finger's in a woman's vagina for the assessment. If a woman has a significant prolapse, you will visually see it, and it looks like a protruding egg. It looks like an egg protruding from the introitus. If the prolapse looks more like a sac than an egg, then it's more likely a uterine prolapse.
Okay.
And I have no background in gynecology, but I've assessed quite a few women, and I've seen the uterine prolapse, and I've seen a significant bladder prolapse, and the cystocele looks like a protruding egg.
All right, thank you.
Hello, I have a question. Are the vaginal estrogen creams still recommended for incontinence?
Very low dose of estrogen locally applied to the vagina. We will sometimes recommend a pea-sized amount of estrogen cream. It depends on the comfort level of the physician about ordering estrogen cream that way. There's tablets called Vagifem that are very low dose. There's estrogen rings. And a woman needs to have a physician assessment and balancing benefit and risk. We always ask about the risk of breast cancer or mother or sister that had breast cancer and you know, whether or not we might make a recommendation for a physician to consider, but it's very, very low dose vaginal estrogen, and this can make the address the atrophic changes and make the tissues healthier, and can really help in terms of treating, significantly treating stress urinary incontinence where there's atrophic changes.
Thank you.
Any more questions? Okay. Well, if you could, great. So this slide is just showing the hand. Oh, go ahead.
There is one question here that just came up in the Q&A, and it
okay.
says, patient is the best candidate for a toileting schedule.
Okay, so I didn't get into treatments, but in terms of toileting methods, if any toileting assistance, any assistance you can possibly provide for toileting is a boon. Prompted voiding has the highest level of evidence of success. And it's not just a schedule of toileting assistance, it's a plan for toileting assistance that's based on the person's normal voiding pattern. So it's based on tracking for 3 or 4 days when it is they need to go to pass urine, and then planning your toileting assistance at that time, at the times that it's been demonstrated this is their pattern, and then monitoring, prompting, praising, highest level of evidence of success, especially with patients that have cognitive impairment.
Okay, thank you, Barbara. This slide is showing the Prompting Continence Care Handbook that Barbara's been speaking to and has helped create, and it also has the campus store link. So the presentation will be sent out within the next 24 hours, and you will have access to this information in the presentation handout. So Barbara, could you just move me through to the next slide?
Sorry.
That's okay. So here's the references for today, and then the next slide. So to wrap it up for today, the next steps for the team, this is just to show where we started back in November with our first community of practice meeting and what we've completed. So our next community of practice education session is on feet and footwear. And we have Dawn Lumello, who is a registered nurse and foot care nurse, who actually, Dawn works in a long-term care home, but also works in an acute care environment doing foot care. So she's going to be doing the presentation on February 1st, which we're very excited about. And then on March 1st, we have the CNIB doing the presentation on vision. So I have as the presenter here Lucia Ricardo, who is the Senior Coordinator at the CNIB, and this is really exciting as well. And I'm under the understanding that there will be a couple, it will be not Lucia alone, there will be a couple of presenters from the CNIB. So, and then again on April 5th, our presentation will be on medication and postural hypertension. So we have an NP that is going to be doing the presentation on that. And speaking a portion, quite a portion to blood pressure medication and that. So, and that's it for today. So I would ask that if anyone could or would, it would be great if you could fill out the poll for us that you see on your screen. And
well, there's another question. The other question says, does anyone use point-click care for assessments? There's a standard assessment that seems not fitting for initial assessments on admission. Has anyone made a quarterly assessment they could possibly share? I'm not sure, Barb, if you can speak to it all, if you have any knowledge of point-click care and the assessment that's in there.
I do not, sorry.
All right.
There is an assessment for urinary incontinence and for bowel in the handbook. A chapter and an assessment form, a suggested form for both bladder and bowel in the continence handbook.
And am I correct if I say the nominal fee for that book is $10?
Yeah, I don't recall the exact price, but it's a minimal amount of money for the book.
Okay.
what we can do with that question too is we could reach out to the coordinators across the province and put that question forward, so when they're visiting with their homes and that, they could be asking and get back to the question and see if we can get a response to it.
Barb, I wonder if you could clarify something for me. You mentioned a couple of times, once in terms of the bowel assessment, but also for bladder, you said second level screening. What is level 1 then?
Well, someone mentioned at the very beginning, I think before all the participants were on, that we used to just ask, do you have incontinence? You know, and in our EPR, I built in some basic elimination screen where we ask, you know, some basic questions to start with, and then that triggers for a more in-depth assessment, depending on the answers to those questions in our EPR. And I built in decision support for a bladder scan as well. So if they answer yes to constipation, fecal impaction, to hesitancy, feeling that they've an incomplete emptying sensation to the bladder, any of those kinds of answers to the first screen automatically triggers the decision support to do a bladder scan. And then a referral for, you know, a more in-depth assessment. I have the continence hat here, so I do the second level assessments on the consult model in our center.
Perfect, thank you.
It'd be neat at some point to provide detail about contributing factors and the range of conservative behavioral interventions and what we do to manage neurogenic bladder and bowel. So lots more detail. We just gave you assessment information today, the time that we had.
Yeah. So if there's no more questions, I'd like to take another moment to thank you again, Barbara, for the work you put into this presentation and sharing your wealth of knowledge with us. It's greatly appreciated, and thank everyone for joining.
My pleasure.
And participating. So, and that being said, if you guys could fill out the poll, that would be great. And we'll end the session for today. Thanks everyone for joining us.
Thank you, everyone.
Thank you.
Bye-bye.